billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Assalamu alaikum. My name is Professor Bilquis Shabbir and I am Chairperson Department of Medicine and Professor of East Medical Ward and in charge Telemedicine, King Edward Medical University. So this lecture is going to be a continuation of the previous one, where we talked about the various ECG vectors. We talked about how they are augmented, how they are represented, and how they are conceived in the various types of leads in the 12-lead ECG. And we also talked about the various views from which the different leads look at the heart via the ECG waveform. Today we are going to talk about the waveform itself, right? So everybody would be remembering from their knowledge of physiology the basic ECG. I'll first make you revise. This is the P wave. This is the PR interval, this is the Q wave, this is the R wave, this is the S wave, this is the QT interval, this is the T wave, and there's a gap before we have again the P wave, right? So P wave, Q, R, S, T, right? So this is the PR interval and this is the QT interval. Right? So this is in short the representation, graphic representation of an ECG. Now we'll talk about what does each of this part of the wave indicates and how do we go along the course of the action potential across the various parts of the conducting system of the heart. For that, first of all, I'll just move this to this side and make the lighting better. Yeah, this is fine. I'll draw the conducting system of the heart. So you can see this is the right atrium, sorry, the left atrium, the right atrium, right ventricle, the left ventricle. These are generally bigger as compared to the right side. So this is how roughly our system goes. And in the right wall we have the right atrium, or in the wall of the right atrium we have the SA node. Lower part of the AV septum we have the AV node. Then we have the bundle of His, and the bundle of His divides into right and left. So this is bundle of His. This is the left bundle branch. This is the right bundle branch, and these are the Purkinje fibers which get diffused into the walls of the ventricles to conduct the ventricular impulses, right? So generally with this diagram we'll proceed further. I hope this is pretty clear. Yeah. So normally the SA node starts off the cardiac conduction cycle, right? So if we look at the SA node, it sends fibers into the walls of the atria, right? And all of them eventually direct into the AV node, right? You remember last time when I took the first presentation, I explained to you the very basic of ECG, that if the flow of the vector or the current is from the negative pole to the positive pole, like this, the deflection which you see on the ECG would be a positive one, right? And if it is away from the positive pole, the deflection would be a negative one. So basically the waveform which I showed you is the waveform we see in lead 2 ECG. Lead 2 ECG, if you remember, is the lead which connects the right upper limb to the left foot, goes in this direction. This is positive, this is negative, and hence we are looking at the heart in this way, right? So this is what I'm going to, the waveform which I showed you is a typical normal waveform of that lead, that is lead 2. So I'll explain according to that. So this is the positive electrode on the left lower limb. This is the negative electrode, and the current is flowing, the net current is flowing in this direction from the SA node to the AV node, right? Because of a mean of all the various vectors, the small impulses which are conducting from the SA to the AV node, the mean is the big vector which is going from the SA to the AV node, right? Now, I told you last time, we always look at life from the brighter aspect, from the positive aspect. So we are looking at the heart from the positive aspect. So looking from downwards, a reflection coming downwards would be positive, right? That understood? Agreed? All right. So this is the first positive deflection you see on the ECG. It shows atrial depolarization, and it is known as the P wave. Understood? All right. We move a step forward. Now, from the SA node, we have reached the AV node. Now, the AV node has a delay period of around about 1 second. These are slower conducting fibers, right? So it sort of halts the impulses which are pouring in from the SA node for about 0.1 seconds and collects them. So I told you last time that one is a positive deflection when the flow is from the negative to the positive. The other is the negative deflection when the flow is from the positive to the negative. And then there is an isoelectric or a flat line when either the conduction is too slow or the conduction is in such a way that it falls perpendicular. So there are equal impulses going from here and equal impulses going from there. So in this particular scenario, we have a conduction delay of about 0.1 seconds, right, normally. and that is at the point of AV node, right? So this would be projected in the ECG waveform in form of a small flat part, right? And this is what we call the PR interval, right? Now this PR interval, you have been told about the bradyarrhythmias, and if not, just to revise, there are various types of heart blocks. Heart blocks is when there is a block of the impulses going from the SA to the AV node. So in the first degree heart block, the PR interval is longer, so the delay is longer. In the second degree heart block, it varies according to certain number of impulses reaching the bundle of hairs and some not being able to reach and pass through the AV node. So there are skipping sort of beats. And the third type of AV block is when the atrium is beating on its own and the poor ventricle takes up its own contractions because it's not receiving anything from the AV node, and they run independently. So there's an absolute block at the level of the AV node, right? So these are the various types. This is the reason, this is the theory behind the various types of blocks which you have been already taught or would be taught, right? We'll go into the detail when we go into the detail of the blocks, right? Now, what text? From the AV node, the impulse passes through the small bundle of hairs into the left and the right bundle branch. Now, it is made like this that the left part of the heart is predominant. It is thicker and it has more fibers. And so is true about the conducting tissue of the heart as well. So basically, the left bundle branch, it predominates. It predominates in a way that it sort of creates a net vector in this fashion. So the right bundle is also conducting impulses, the left bundle is also conducting impulses, but since the left bundle is more predominant, the net vector is in this fashion. Now look at the point of view from the positive eye. What do you see? From the left foot, the vector which is going slightly towards the right and upwards through the septum originating from the left bundle branch, how would it appear as? Would it be a positive deflection or would it be a negative deflection? It would obviously, since it is away from the positive, it would be a negative deflection. So this is what we call a Q wave, right? Now what happens? Now when the impulses have passed through the bundle branch, they would go into the Purkinje system. This Purkinje system is innervating, I'll take the red one. This Purkinje system is innervating the walls of the ventricles, right? So they are fast conducting fibers, right? So what they would do is they would cause a net impulse in such a way that the impulse passes from the positive to the negative side. the next step is that the impulses following their flow from the right and the left bundle branch, they go into the Purkinje fibers. These are fast conducting fibers. The Purkinje fibers, they start generating impulses in this way. So the general flow of impulses is through the wall of the right and the left atrium, from the negative towards the positive. But guess what? What is the predominant site in way of structure and way of thickness? That is the left ventricle, right? So what happens is, despite the fact that the right ventricle is also discharging impulses, but the impulses, when you talk about the net vector, they are predominantly towards the left side. So outwards and towards the left side. So the net vector would look somewhat like this. This is net of the small impulses which are taking place throughout the wall of the ventricles to the Purkinje fibers. Now looking at it from the positive eye, what do you see? A positive deflection, right? So this is the positive deflection which you find in form of the R wave, right? So we have done the P wave, that is atrial depolarization. We have done the PR interval, that is the stay time in the AV node. We have done the Q wave, that is the bundle branches which are leading predominantly the left bundle predominating over the right bundle. We have talked about the ventricle depolarization, and now there's a time which is required to sort of move as the impulses go up. So this is how the impulses are going. The Purkinje fibers are going up like this. So initial vector is like this, and then this is the base of the ventricle. As it goes up, the net vector becomes like this, right? So at the end of this positive deflection, just because of this net vector occurring at the apex and the thicker wall of the ventricle, as the Purkinje fibers go up towards the base of the heart, we see that they go in the opposite direction predominantly. So looking from the positive eye, what would we see? Something going away from the positive electrode, and that will always come as the negative deflection, right? So that accounts for what we call the S wave. So this is a theory behind the Qrs complex, that is the depolarization of the ventricles starting from the bundle branches, going into the Purkinje fibers, traveling from the apex to the base of the ventricles, and resulting in this typical waveform which is called the Qrs complex. Now see the charges here. Right now the positive are inside more as compared to the negative, right? Now this has to flip over. So there is some time when the ventricles go static for some time before they go back into the stage of repolarization. That is what we call the flat line of QT interval. the last part of the ECG waveform. What has happened till now is that all the wall of the ventricles have repolarized, and there is a period when all the positive electrodes have come to the outside, and there is a gap. Next is that the ventricle has to repolarize, right? That means the negative have to go inside. So negative going inside, negative going inside. So if we change the direction of the current, it would be somewhat like this. So negative moving away from the positive, it would be somewhere. So the net vector would be this, and this would appear in the form of the T wave, a positive deflection, which indicates ventricular repolarization, right? So again, to summarize, we start from the SA node, various impulses passing from the various fibers, interatrial fibers, onto the AV node, but the net reflex, the net vector being a bigger vector which is going towards the positive limb lead. So it would be a P wave. An area of delay at the AV node of about 0.1 seconds, that is the PR interval. Passing through the bundle of hairs into the right and the left branch, bundle branch, and the net vector being a vector going in this direction away from the positive node. So that would be the negative deflection of the Q wave. Then collectively entering into the Purkinje fibers, initially they would go like this. They would the current or the stimulus would go in this direction, and since we know the thickness of the left ventricle is more as compared to the right ventricle, the net vector would be in this direction, which results in the formation of the R wave. And then as the Purkinje fibers move around along the walls of the ventricles towards the base of the ventricles, they go in the opposite direction. So net vector is opposite to the positive I, and that would be in form of the S wave. And then because it has depolarized, there are positive charges which have to, the net charge has to flip, but there is a little transient time before this flipping over takes place. That is represented in form of the ST segment, and then the flipping takes place. So there is movement of the negative charge towards the inside, away from the positive electrode, and this is where the ventricular repolarization is taking place, and this is seen as the T wave, right? So generally these are the basic concepts of ECG, and this is how the basic waveform originates, and hopefully I've tried to make it as easy for you as possible. You can refer to various books on ECGs, starting from ECG Made Easy. That is the simplest form of books on ECG, which can be read if you do have a little concept and you have especially seen some ECGs. It takes maximally, I think, 1 or 2 days to go through that book. So ECG Made Easy and There are several books for that, but generally this is the concept of a waveform. So I'll end here, and inshallah this would be followed by consequent sections on the various diseases of the heart, where the first thing we'll be talking about would be the ECG abnormalities. So if you know the basics, if you know the normal, you will be knowing the abnormal, right? Till then, take care. Allah Hafiz.